This is the continuation of the previous lecture of hyperthyroidism, and in this lecture we will be discussing the diagnosis and the treatment of hyperthyroidism. Hyperthyroidism is primarily diagnosed through biochemical tests that measure serum levels of free T3, free T4 and TSH. Additional evaluation includes thyroid antibody testing, radioisotope uptake studies and imaging, along with other supportive investigations as needed. The first-line investigations are serum T3, T4, and TSH levels. Most patients are with elevated serum T3 and T4, and serum TSH is undetectable in primary thyrotoxicosis. But TSH can be raised in a very rare syndrome of secondary hyperthyroidism caused by TSH-producing pituitary adenoma. Now, the antibody measurement, the TSH receptor antibodies present in more than 95% cases of the grave disease. An approach to evaluating an adult suspected of having hyperthyroidism, once biochemical thyrotoxicosis is confirmed, that is, when laboratory results show a suppressed TSH with elevated free T3 and T4 levels, the first consideration is whether the patient is clinically thyrotoxic, meaning they show classic signs and symptoms of overactive thyroid gland, or it's a acute non-thyroidal illness, which is also known as the sick euthyroid syndrome, as this can sometimes cause the abnormal thyroid function test. In such cases, it is recommended to repeat the test after the acute illness has resolved. If the patient is clinically thyrotoxic, then the next step is to screen for TSH receptor antibodies. If TSH receptor antibodies are positive, then this confirms the grave disease. If TSH receptor antibodies are negative, it does not completely rule out Graves' disease. In such cases, a thyroid scintigraphy or radioiodine uptake scan should be performed to confirm the diagnosis and differentiate it from other causes of thyrotoxicosis. If TSH receptor antibodies test is not available, then screen for the features of grave disease like diffuse goiter, ophthalmopathy, myxedema. If these features are positive, then check for signs of non-grave thyrotoxicosis, such as recent pregnancy within the past 6 months, neck pain or flu-like symptoms, the use of drugs like amiodarone or iodine. If these features are not present, then this confirms the grave disease. If these non-grave thyrotoxic features are present, then we go for thyroid scintigraphy or radioiodine scan. And if the features of grave disease is not present, then we also go for thyroid scan. This scan does not just confirm that the thyroid is overactive, it tells you why it is overactive. So it points directly to the cause of hyperthyroidism. Thyroid scintigraphy is also known as thyroid scan, is an imaging test where a radioactive tracer, usually technetium-99, is given to patient. This tracer is taken up by the thyroid gland cells and a gamma camera then create an image showing how actively different parts of the gland are functioning. As the pituitary glands secrete TSH, which bind to the TSH receptor on the thyroid follicular cells, they stimulate the gland to trap iodine and synthesize thyroid hormone. Now, in grave disease, the body produces autoantibodies that mimic TSH. These antibodies continuously activate the TSH receptor everywhere in the thyroid gland. As a result, every cell in the gland becomes overactive and pulls in more iodine or tracer and produces excess hormone. In grave disease, during thyroid scan, we give a small dose of radioactive tracer, technetium-99 or radioiodine. Since all cells are overactive, the tracer is taken up uniformly throughout the gland. This image, showing a bright, symmetrical, butterfly-shaped thyroid, this is the classic diffuse uptake pattern that we see in case of grave disease. In toxic multinodular goiter, certain nodules within the thyroid gland become autonomously overactive, trapping more iodine or tracer and producing excess thyroid hormones. On thyroid scintigraphy, this appears as a patchy uptake pattern reflecting areas of overactive nodules functioning independently of TSH control. In toxic adenoma, the thyroid nodule becomes autonomous, meaning it produces thyroid hormones without TSH stimulation. On a thyroid scan, the adenoma shows intense tracer uptake, while the surrounding normal thyroid tissue appears faint or suppressed. This occurs because the elevated hormone levels from the adenoma suppress pituitary TSH secretion, reducing activity in the rest of the gland. In case of thyroiditis, the thyroid cells are damaged by inflammation. They break open and release stored hormone into the bloodstream. Because hormones are just leaking out, not being newly synthesized, the glands stop trapping iodine or tracer. As the result, the tracer uptake is very low or absent in case of thyroiditis. Other non-specific tests include there is increased level of SGOT and SGPT levels. In hyperthyroidism, the thyroid hormone stimulates the osteoblast, leading to accelerate the rate of bone remodeling and turnover. The bone-specific isoenzyme alkaline phosphate is released into the circulation as the byproduct of increased osteoblast activity. Because of increased bone remodeling and turnover, there is also increased level of calcium in the blood. The thyroid hormone increases gluconeogenesis and glycogenolysis, so there is increased blood glucose level. There is also low level of potassium in the blood, which we already discussed in thyrotoxic hypokalemic periodic paralysis. Now, treatment. Propranolol is indeed used for symptomatic relief in Graves' disease and thyrotoxicosis. It helps control tachycardia, tremor, and anxiety, and is also a first-line agent in thyrotoxic crisis because it blocks beta receptors and partially inhibits the peripheral conversion of T4 to T3. We can start with usual oral dose for thyrotoxicosis is 10 to 40 milligrams every 6 to 8 hours, with total daily doses typically between 30 to 160 milligrams per day, though occasionally higher, up to 240 to 320 milligrams per day, can be given in severe cases. Dose adjustment is guided by heart rate, aiming to maintain the heart rate below 90 beats per minute. Propranolol has a proven therapeutic role in thyrotoxic hypokalemic periodic paralysis. High-dose non-selective beta blockers, for example propranolol 3 mg per kilogram orally or intravenously, can rapidly correct hypokalemia and paralysis by reducing intracellular potassium shift. And then the antithyroid drugs. The most commonly used are Carbimazole and its metabolites, Methimazole. Propylthiouracil is equally effective. These drugs reduce the synthesis of new thyroid hormone. Carbimazole may also have immunosuppressive action, leading to reduction in serum TSH receptor antibodies concentration. Antithyroid drugs are typically introduced at high dose. Carbimazole should be given at the dose of 40 to 60 milligrams daily. For propylthiouracil, 400 to 600 milligrams daily. Although the lower dose are reasonable in individual with only modest elevation of T4 and T3. Subjective improvement occur within 10 to 14 days and render the patient clinically and biochemically euthyroid 6 to 8 weeks. At this point, the dose can be reduced and titrated to maintain T4 and TSH level within their reference range. In some cases of Graves' disease, the levels of T4 and TSH fluctuate, sometimes indicating hyperthyroidism and at other times hypothyroidism, even when the patient is taking medication regularly. This occurs due to rapid variations in the concentration of TSH receptor antibodies in the blood. To stabilize thyroid function in such patients, we can use the block and replace therapy, where high-dose carbimazole is given to completely block thyroid hormone synthesis, and levothyroxine is added to provide the necessary amount of thyroid hormone required by the body. The adverse effect of antithyroid medication, the most common, is a rash. Agranulocytosis is the rare but the serious complication, but is reversible on stopping treatment. The patient should be warned to stop the drug if they develop severe sore throat or fever while on treatment. PTU associated with a risk of hepatotoxicity, therefore considered second in therapy to carbimazole, used only in pregnancy and breastfeeding. Thyroidectomy. The common indication include the large goiter size, the poor adherence, especially in a young patient, and if there is a recurrent thyrotoxicosis. The complication of thyroidectomy, the most common complication of thyroidectomy is hypothyroidism, and sometimes there is transient hypocalcemia. Then we can use the radioactive iodine for the treatment of hyperthyroidism. It is indicated if the patient is more than 40 years and if there is recurrence following surgery. It is contraindicated if there is pregnancy or planned pregnancy within 6 months of treatment, or if there is active grave ophthalmopathy and its complication is hypothyroidism, which is most common. That's all for hyperthyroidism.